Welcome back. Always challenging being the first speaker after lunch. I'll do my best to keep you awake, mainly by asking challenging multiple choice questions. So next 45 minutes we'll cover some questions on hyperkalemia and then launch into some acid-based questions that are typical of what you might get on the boards. So without further ado, first question is a 41-year-old female with lupus nephritis and chronic kidney disease on prednisone candesartan. She comes in and her blood pressure is a little high. She has moderate edema and her labs are notable for a K of 6.3, bicarb is 18, creatinine is 1.6. And the question is, which of the following would not be appropriate in the management of this patient? Hydrochlorothiazide, discontinue candesartan, fludrocortisone, low potassium diet, or sodium polystyrene sulfonate. Okay, it's an easy one to get you started. All right, so that's interesting. So so half of you chose C, which is probably was at least the answer that I was thinking of when I designed the question. You have to realize designing good board questions is challenging. So this patient obviously has multiple reasons to have hyperkalemia. And so if we just go over why patients get hyperkalemia, it can be either due to one of three things: either increased intake, decreased urinary K excretion, or shift out of cells. Although generally shift out of cells doesn't cause chronic hyperkalemia. The diagnosis of decreased urinary K excretion, again, some sort of urinary K index. I do not recommend just a spot urine potassium concentration. For the boards, usually they'll give you a 24-hour urine, and if the potassium is less than 40, that is inappropriately low. And the causes of urinary K excretion, if you think simplistically, are really twofold. Either the patients have inadequate, so if you think about K secretion occurring primarily in the cortical collecting duct, you either have decreased flow to the collecting duct, either because your GFR is low or you're profoundly pre-renal, or you have decreased collecting duct K secretion, which, as you know, is driven by the reabsorption of sodium, driven by the renin, angiotensin, aldosterone system. So anything that leads to decreased aldosterone, like adrenal insufficiency or hyporeninemic hypoaldo, medications that inhibit the renin, angiotensin, aldosterone system, including NSAIDs, ACE inhibitors, ARBs, heparin, aldo blockers, and CNIs, and drugs that block the sodium channel, all of these cause hyperkalemia. So in this particular patient, we have at least three causes. Firstly, she has CKD. Secondly, she's on candesartan. Thirdly, being a lupus patient with mild CKD, she's at risk of having hyporeninemic hypoaldosteronism, which can be contributing. And then finally, not listed on here, she may be eating more K than is appropriate for her level of renal insufficiency. Whoops. So in terms of possible treatments for this, obviously stopping the candesartan would be appropriate. We often give thiazides as a way to try and get rid of potassium, so that essentially increases the delivery of sodium to the collecting duct. Low potassium diet, sometimes K-Electrolyte is needed. Fludrocortisone is in fact an appropriate treatment for hyporeninemic hypoaldosteronism, but only in patients who have low extracellular fluid volume and controlled blood pressure. Someone who's hypertensive and edematous shouldn't get fludrocortisone. So that was the reason for that answer. Okay. Next, a 48-year-old female evaluated for several weeks of fatigue, nausea, mild generalized abdominal pain. On exam, she's thin and tanned with a blood pressure of 90/45. Her palmar creases are hyperpigmented. She has a K of 6.1, glucose of 40. The rest of her labs are as shown. And the question is, which of the following tests would be most likely to establish the diagnosis in this patient? Is it the plasma renin and aldo, serum cortisol at baseline and after ACTH, serum C-peptide, iothalamate GFR determination, or genetic testing of the sodium channel gene SCN4A? Let's see if you've recovered from lunch yet. Excellent, yes. So all of you spotted that this is a case of adrenal insufficiency where cortisol pre and post colchicine would be the appropriate test. Okay, another case of hyperkalemia for you. A 26-year-old male with AIDS admitted with pneumocystis pneumonia, treated with prednisone and IV trimethoprim sulfur. On exam, he's tachypnic with diffuse RALs, and his case 5.6. Which of the following would be the best treatment for the hyperkalemia in this patient? Is it fludrocortisone, sodium bicarbonate, discontinue trimethoprim sulfur and start pentamidine, discontinue trimethoprim sulfur and start clindamycin primaquine, or none of the above? Oops, sorry. Okay, now you can vote. Good, getting a good response now. All right, so most of you chose either C or D. So you're correct that you've got to stop the trimethoprim sulfur. So the trimethoprim moiety in Bactrim is a weak organic cation that inhibits the ENaC, the epithelial sodium channel. So it acts just like a miloride, like a case-bearing diuretic. The problem is that pentamidine does the exact same thing, also an organic cation that inhibits ENaC. So swapping trimethoprim for pentamidine would be wrong. So you have to choose something else, such as clindamycin. Okay, next. A 57-year-old female with end-stage renal disease secondary to diabetic nephropathy, is maintained on chronic hemodialysis, now seen on a non-dialysis day, and her K is 7.1. Creatinine is 4.5. All of the following would lower the serum potassium substantially except insulin and glucose, sodium bicarbonate, albuterol, sodium polystyrene sulfonate, or whatever your favorite K resin, binding resin is, and hemodialysis. Okay. Excellent. So most of you chose B, which I would agree with. So in the treatment of hyperkalemia, once you've given calcium if it's needed in patients with EKG changes, you want to shift the K into cells, which is of course transient, with either insulin or beta-2 agonist. Sodium bicarbonate is always listed as something that does that by exchanging K plus cations for hydrogen ions across the plasma membrane. But there's good evidence that it doesn't work well in general. If it works at all, it works only in patients who are quite acidotic, and particularly in end-stage renal disease patients, it has very poor efficacy. So we almost never use it. And here's one of the well-cited studies from Bloomberg showing the amount to which the serum potassium was lowered in a cohort of, in a large series of patients given either insulin glucose, albuterol, or epinephrine, bicarb, or treated with hemodialysis. As you can see, the patients given bicarb had really no lowering of potassium. Okay, next. A 23-year-old male with diabetes mellitus presents with 5 days of polyuria, polydipsia, and abdominal pain. And his K is 6.5. Bicarb is 15. Glucose is 296, BUN is 38, creatinine 1.6, and urine shows, let's see, pH of 4.5, 2 plus ketones. Which of the following statements about the total body stores in this patient is most likely to be correct? Total body potassium depleted, total body potassium overloaded, normal total body potassium stores but redistributed into the extracellular space, normal total body potassium stores but redistributed into the intracellular space, or none of the above. Okay. All right. So half of you chose C, which is a good guess. But A is actually more correct. Let's see. So the idea is, so this is a patient that has DKA, but this, I think, refers to any patient that has hyperglycemia, I think, due to diabetes. So in these patients, there is indeed a shift of potassium out of cells, and that's because insulin is normally required to drive the sodium pump and drive potassium back into cells. But the important thing is that elevated amounts of potassium in the extracellular fluid it increases the amount excreted, both because the patients are absolutely hyperkalemic and also because they're having an osmotic diuresis. And so even though the patient looks hyperkalemic, they actually have K depletion. And the reason you'll know that is once you start giving insulin to normalize the glucose, they become hypokalemic. So that's one of the major complications of the treatment of DKA to be aware of. Okay, next. 65-year-old female with a history of hypertension, diabetes, AFib, ischemic cardiomyopathy. She presents with 1 week of nausea, confusion, blurry vision, and hallucinations. Her meds are insulin, carvedilol, amlodipine, furosemide, and digoxin. And their EKG shows bradycardia, peak T waves, and widened QRS. And her sodium is 134, K of 6, bicarb 21, creatinine 1.9. Which of the following would be the most appropriate initial treatment for this patient? Is it calcium gluconate, hydrocortisone, hemodialysis, digibind, or none of the above? Okay. All right. That's a tie between A and D. So I would think D would be more correct. Let's see if I have an explanation. I do not. So this is a patient that likely has dig toxicity, right? So the symptoms are consistent with it, and patient has some EKG changes that probably are mostly due to the hyperkalemia. So the question is, how would you treat this? There are folks who argue that you should not give calcium in this setting because DIG works by increasing intracellular calcium. That's, after all, how it works as a positive inotrope in the heart. And there's some evidence that if you give these patients calcium, it can cause asystole. And so the recommended treatment is to move straight to digibind. I cheated a little because I didn't give you a dig level. Obviously, you would want to know the dig level before you went ahead. But that's probably the safer option, is to reach for digibind immediately. Okay, next. A 48-year-old male with hypertension and ESRD underwent cadaveric transplantation followed by ATG, mycophenolate, and prednisone. Post-op, the patient's oliguric and serum K is up to 6.5, so he gets 60 grams of Kayexalate and sorbitol as an enema. 12 hours later, the patient complained of diffuse abdominal pain, and on exam, the abdomen was distended and tympanitic with hypoactive bowel sounds. Which is the most likely cause of abdominal pain in this patient? Ileus due to hypokalemia, stress-induced gastric ulceration, mycophenolate side effect, adrenal insufficiency, colonic necrosis. Okay, hopefully fairly obvious. And maybe a thing of the past now, with new resins coming out. So most of you identified colonic necrosis as a complication of sodium polystyrene sulfonate, especially, although maybe not necessarily with sorbitol. So these patients present with abdominal pain, distension, or GI bleed. In some cases, as long as 11 days after treatment. Risk factors include being old, having ESRD, being post-op or critically ill, and the colon is most commonly affected, but anywhere along the GI tract can be involved. And pathology shows deposition of SPS crystals in the intestinal wall that looks like ischemia. Some animal studies have suggested that sorbitol is the culprit, but more recent papers have suggested you get the same incidence even in SPS without sorbitol. So I don't think that's resolved. Okay, now on to something different. An 18-year-old female is brought in after a suspected suicide attempt. She has unidentified pills in her pocket, and on exam she's obtunded with a blood pressure of 101/64, heart rate 112, reps of 30, temperature of 101.8. Here are her lights, which include a bicarb of 15 and an arterial pH of 7.35 and PCO2 of 25. I'll give you 2 seconds to digest that. Okay, which of the following is most likely to be helpful in this patient? Forced alkaline diuresis, IV ethanol, insulin drip, glucagon, or potassium citrate? I know it's hard to do all the calculations in a short period of time. But yeah, everyone chose forced alkaline diuresis, which I'd agree with. So if you work through this, patient's acidemic and has a metabolic acidosis. The PCO2, if you use Winter's formula, is just a hair lower than you would expect. So probably a primary respiratory alkalosis as well. And the anion gap is elevated. If you do the delta-delta, then the change in the anion gap is 26 minus 10, which is 16. The change in the bicarb is 24 minus the actual bicarb of 15, which is 9, and the ratio is 2. So it looks like a triple acid-base disorder, that there's also perhaps a superimposed metabolic alkalosis. And this is a patient who's got the triple hyper vital signs, as I like to put it. Temperature's up, her heart rate's up, and her respiratory rate is up, and we know she'd had a drug overdose. So this is salicylate poisoning until proven otherwise. Obviously, you check a salicylate level, but the treatment for salicylate poisoning would be alkaline diuresis and or hemodialysis. Okay. I think I'm going to skip that and move on. Next case, 29-year-old female found unconscious and brought into the ER. Blood pressure's relatively normal, but she's comatose and has an alcoholic fetor. And her labs include a bicarb of 11, creatinine is 1.6, lactate is 1, CK is normal, serum osmolality is 300, pH 7.22, PCO2 of 24. And serum levels of ethanol, ketones, beta-hydroxybutyrate, and salicylate were all negative. So, the most appropriate first step in the management of this patient, is it forced alkaline diuresis, dopamine, fomepizole, thiamine, or hemodialysis? Great. Easy, right? Yeah. So you're divided between fomepizole, most of you, and hemodialysis. So fomepizole is actually the right answer here. So this is if you work through it, it turns out to be a pure metabolic acidosis with an elevated anion gap and a delta-delta of about 1. So pure anion gap metabolic acidosis. She has an osmolar gap. So if you plug in the numbers, her calculated serum osmolality is 266, and they're measured with 300. So she's got a huge osmolar gap of 34. Anion gap plus osmolar gap, either alcoholic ketoacidosis, but she didn't have keto acids, not propylene glycol, because that's really an in-hospital intoxication. So it's either ethylene glycol or methanol. Hemodialysis is absolutely appropriate in a patient like this, but it doesn't precede blocking the metabolism of the alcohol to its toxic metabolites. That has to start first. And is probably the most important life-saving thing you do. So you should give fomepizole first, and then, if needed, start dialysis. And it doesn't matter whether it's ethylene glycol or methanol, you treat it pretty much the same way. Next, a 16-year-old male has a witnessed grand mal seizure and is brought immediately to the emergency room. He's postictal and has vomitus on his shirt. Blood pressure is 120/83. Labs are notable for bicarb of 14, creatinine 1.1, CK is normal, serum osmolality is 289, tox screen is negative, ketones negative, pH is 7.3, and PCO2 is 33. The most appropriate first step in the management of the acidemia in this patient is alkaline diuresis, ethanol, fomepizole, hemodialysis, or none of the above. Okay, so the majority of you chose E, which is the correct answer. So this is a patient that's postictal and most likely has a lactic acidosis, which is transient, is very common after seizures, can be quite severe. And so really the solution is not to treat the acidosis and just repeat the labs in 15 or 30 minutes, and oftentimes it's already resolved by then. But if you work through all the numbers, you'll see that it's an anion gap metabolic acidosis. There's also a component of respiratory acidosis and metabolic alkalosis, neither of which are very surprising, but no osmolar gap. Okay, next. A 48-year-old male in the ICU is intubated for respiratory failure due to severe pneumonia, paralyzed with vecuronium and sedated with lorazepam. He is hemodynamically stable and on no pressors, but a renal consult is called because they identify metabolic acidosis. And his bicarb is 16, creatinine is 1.1, lactate is 8, serum osmolality of 312, pH is 7.4, and PCO2 of 24. The most appropriate next step, should it be dopamine, dobutamine, abdominal CT, discontinue the vecuronium, or discontinue the lorazepam? Okay. Excellent. So most of you chose E, which is the correct answer, discontinue the lorazepam. So this is a patient that most likely has propylene glycol poisoning, which causes a lactic acidosis, so that's why the lactate is elevated, and causes an osmolar gap, so that's why the serum osmolality is elevated. And if you formally calculate it, which if you don't have time, I encourage you to do in your spare time so that you get quick at doing these, you'll see that this is actually a mixed metabolic acidosis and respiratory alkalosis, pure anion gap acidosis, and osmolar gap. And the differential is as shown here, but obviously given the context, this is most likely propylene glycol poisoning. Next, 78-year-old female who's been in the ICU for 2 weeks because of cholecystitis, gram-negative sepsis, hypotension, and ARDS requiring mechanical ventilation. And the renal consult is called because she has a persistently low serum bicarb. Her meds are imipenem, acetaminophen, dopamine, and noradrenaline. And so her bicarb is 18, creatinine is 1.4, lactate 1.6, pH is 7.27, PCO2 of 41. Which of the following are appropriate in the management of the patient's acid-base disturbance? CT scan to rule out ischemic bowel, discontinue acetaminophen, add colistin to cover carbapenem-resistant enterobacteria, alkaline diuresis, or A and C. Okay, everyone voted? Okay, so most people chose B, which is discontinue acetaminophen, which is correct. So although we don't have any measurements of it, the context suggests that she might have a pyroglutamic acidosis. She's on acetaminophen, she's female, she's in the ICU, she has sepsis, and she doesn't have any other good reason to have it. One of the red herrings here is that she has a slightly elevated serum lactate level. So the question is, could that account for this acidosis? And the answer is no. So one way to look at it is to calculate the anion gap, which is 134 minus 117, which is 17. So the anion gap is about 7 more than it should be in milliequivalents per liter. So if that were contributed by lactate, the lactate level should be at least 7 millimoles per liter. Instead, it's 1.6. So the contribution of a lactate of 1.6 to the anion gap is only 1.6. So that's how you know there's something else going on. Here are the calculations. And this is just to remind you how pyroglutamic acid is generated, and then it's due to the effects of acetaminophen and sepsis. Okay, next. A 65-year-old woman developed a staph infection of a prosthetic knee and was treated with vancomycin. She developed vancomycin-resistant enterococcus and was switched to linezolid and treated for 6 weeks. And she's now admitted with nausea, vomiting, and abdominal discomfort. And she has a bicarb of 14, lactate of 8.5, AST and ALT are normal, arterial pH is 7.3, and PCO2 is 29. Which is the most likely cause of the acid-base disturbance? Seizure, drug-induced lactic acidosis, ischemic bowel, occult sepsis, or D-lactic acidosis? Okay, take your vote. Let's see. All right, so more than half chose B, which is correct. Few of you chose D-lactic acidosis. Certainly possible, but not the most likely. So actually, sorry, it's not possible because you're actually given the lactate, and it's 8.5. Remember, the regular lab-measured lactate is an L-lactate. So this is an acidosis from L-lactate. If we want to calculate the anion gap, it is 132 minus 113, which is about 19. So the anion gap is about 9 milliequivalents per liter more than it should be. And the lactate level is 8.5 millimoles per liter, pretty close. So I would say L-lactate accounts for all of the anion gap and presumably acidosis here. And so what you have to remember is that linezolid is one of the list of drugs that cause so-called type B lactic acidosis that's not associated with impaired tissue oxygenation, along with seizures, like the case we just saw, malignancies, certain types of leukemias, lymphomas, solid tumors with large amounts of liver mets, liver failure, thiamine or riboflavin deficiency, and a bunch of drugs and toxins that are listed here. Okay, next case. A 28-year-old Asian female with a photosensitive erythematous malar rash and arthralgias is referred to renal clinic because of abnormal lab electrolyte values. She denies vomiting or diarrhea, does not drink alcohol, and does not use laxatives or recreational drugs. And she's got a K of 3.2 and a bicarb of 15. Her urine pH is 6.5, urine sodium is 25, K of 35, chloride of 34. What's the most appropriate management for this patient? Is it loperamide, hydrochlorothiazide, calcium carbonate, K-citrate, 1 to 3 milliequivalents per kilo per day, or sodium bicarb, 5 to 15 milliequivalents per kilo per day? Okay. Good. 80% of you chose D. So this gets to something that we discussed earlier this morning directly. So this is a patient that has a non-GAP metabolic acidosis, okay? And so the first step is to look at the urine anion gap. So just to back up, she doesn't have a urinary diversion, no reason to think this is dilutional acidosis. Looking at the PCO2, this is not primary respiratory alkalosis. So it's between diarrhea and RTA. We look at the urine anion gap. Hers is 25 plus 35 minus 34, which is 26, plus 26. So it's got to be an RTA. Okay? So she's hypokalemic, so it's not a type 4. It's either a type 1 or a proximal RTA. And her urine pH is also elevated, right? So 6.5. So it's actually perfect for a classic type 1 distal RTA. Again, nothing to suggest the type 4. The picture could be consistent with a proximal RTA, but these are rarer. Usually, if you see a case, it should be associated with Fanconi syndrome, and the whole context looks like a patient who might have lupus that's not been diagnosed before. And lupus is, along with Sjogren's, is the most common cause of a type 1 distal RTA. So that's what I think this is here. And the treatment for this, as we discussed, is potassium bicarbonate or potassium citrate in the modest doses sufficient to neutralize your daily acid load, 1 to 3 milliequivalents per kilo per day. Okay, next case. A 54-year-old male with a 12-year history of type 2 diabetes is maintained on insulin and has proliferative diabetic retinopathy. He's referred for proteinuria and found to have a K of 6 with a creatinine of 1.6. Glucose is a little high at 206. Urinalysis is 3 plus proteinuria. The most likely cause of this patient's metabolic acidosis: diarrhea due to diabetic autonomic neuropathy, DKA, solvent abuse, type 1 RTA, or type 4 RTA. Okay. Oops. There we go. So most of you chose E, type 4 RTA, which I would agree with is the best answer. So type 4 RTA due to hyporeninemic hypoaldosteronism presents with hyperkalemia that's disproportionate to the level of GFR, right? So obviously patients with CKD can have hyperkalemia. You see some of the mild CKD and they seem to be awfully hyperkalemic. They probably have hyporeninemic hypoaldo. They also have a non-GAP metabolic acidosis with a positive urine anion gap, but normal urine acidifying ability, meaning their urine pH can be lowered below 5.5. But this is usually a minor part of their clinical picture. They have mild CKD, okay? If they have advanced CKD, then obviously the hyperkalemia is just due to low GFR. And it occurs in patients with diabetic nephropathy and patients with other forms of CKD that have a propensity to cause tubulointerstitial disease, including lupus, obstruction, myeloma or amyloid, HIV, and so on. And it can be mimicked by drugs like NSAIDs, which also suppress renin secretion. Okay, next. A 22-year-old male with HIV infection is started on heart therapy. He's on abacavir, tenofovir, and M-tricytabine. His K is 3.4, bicarb is 18, BUN creatinine is 7 and 0.4, phos is 0.9, uric acid 1.7, UA shows pH of 6, specific gravity 1015, 3 plus glucose trace protein, urine phosphorus is 25, and creatinine is 38. The most likely cause of this patient's acid-base disturbance, is it HIV-related diarrhea, D-lactic acidosis, respiratory alkalosis with metabolic compensation, hepatic failure-associated RTA, or antiretroviral medication toxicity? Okay, 100%, wow. Let's hope that's the right answer. Yep. So this patient has a non-GAP metabolic acidosis, has an inappropriately alkaline urine and hypokalemia. So this could be either a type 1 or a type 2 RTA. But the other clues are the low serum phosphorus, which is due to renal phosphorus wasting. There are several ways of diagnosing it, but I find the simplest is just a fractional excretion of phosphate, normal 5 to 15%. This patient's is 29%. Hypouricemia, I didn't list that on there, and as you noticed in the UA, glycosuria despite normal glycemia. So this patient has Fanconi syndrome. This is a type 2 proximal RTA, and the obvious cause in this particular patient was the tenofovir. Next, a 22-year-old female presents with polyuria, constipation, and fatigue. She denies taking any prescription or over-the-counter meds. Blood pressure is 96/54. Exam shows only mild bilateral parotid enlargement, and her K is 2.9. Bicarb is 38. Urine sodium is 15. Urine potassium is 17. Urine chloride is less than 5. UA shows pH 4.5 with 1 plus ketones. What is the most likely cause of this patient's hypokalemia and alkalosis? Liddle's, Gittleman's, Conn's, diuretic abuse, or bulimia? Okay, time's up. Okay, so the majority of you chose E, bulimia, which is the correct answer. So this is to remind you that in the setting of metabolic alkalosis, which this patient has, the chloride is the best indicator of volume depletion because unlike the sodium, it's always low. Okay? So if you look at patients with cryptogenic metabolic alkalosis, by excluding hyperaldosteronism, patients who are hypertensive, in all these other cases, the urine chloride is low, then it's not diuretic or Bart's or Gittleman's, it's got to be surreptitious vomiting. Hers was less than 5, so that's what she had. She had parotid enlargement, which is classic for bulimia, as you know. Okay. A 48-year-old male with congestive cardiac failure is seen in clinic for dyspnea and orthopnea. He has known systolic dysfunction with an EF of 20% and is maintained on aspirin, carvedilol, furosemide, metolazone, and candesartan. Exam shows bilateral diffuse crackles and 1 plus edema. And he has a K of 3.5, bicarb of 31, creatinine of 2.6, pH of 7.51, PCO2 of 42, and PO2 of 68. So, multifactorial. All of the following are contributing to this patient's alkalemia except metolazone, candesartan, hypokalemia, secondary hyperaldosteronism, renal failure. Okay, let's see what you guys think. Yeah, this one always trips people up. So half of you thought renal failure, which is probably not the best answer, and a quarter of you thought candesartan, which is the correct answer. So just to remind you, that the causes of hypokalemic metabolic alkalosis include increased delivery of sodium to the collecting duct and increased aldo effect. Okay, all of those do the same thing. So secondary hyperaldosteronism, hypokalemia also contributes to metabolic alkalosis. The metolazone, which is a thiazide diuretic, does. Candesartan does not. It does the opposite, right? It blocks angiotensin II, so in theory it would cause acidosis, if anything. The question is, what's the contribution of renal failure? And so the contribution of renal failure is it decreases the ability to adapt to an acid-base disturbance. Under normal circumstances, we ingest net acid, and so renal failure causes acidosis because you can't excrete it. But in a patient that has alkalosis, the contribution of renal failure is an inability to compensate by excreting bicarb. And so anyone who has alkalosis will have worse alkalosis because they have renal failure than if they did not. So that's the reason why E isn't the best answer. Okay, next case. A 16-year-old male presents with muscle weakness. He's had several prior episodes that have resolved. He denies vomiting, doesn't take any meds, he says. And his case, 2.8 with a bicarb of 33. His urine lights are as shown, 33, 48, and 72. All of these disorders could be the cause of this patient's alkalosis, except Barter's, Gittleman's, loop diuretic abuse, thiazide diuretic abuse, or surreptitious vomiting. Okay, let's see what you think. All right, you all agreed surreptitious vomiting. So the clue was the very high urine chloride, right? So it's got to be either diuretic abuse or Barter's. And we don't know which it is, but it can't be because of vomiting. 31-year-old male with several-month history of reflux and heartburn is admitted with nausea, vomiting, abdominal pain, confusion. He avoids seeing doctors and takes only over-the-counter meds, including ibuprofen, omeprazole, calcium carbonate, and sodium bicarbonate. And on exam, he appears dehydrated and has a tender abdomen. His bicarb is 38. A few other abnormalities that are shown down there, including creatinine of 4.1, calcium of 12.1. What's the most likely diagnosis? Vomiting-induced metabolic alkalosis, hyporeninemic hypoaldo, primary hyperparathyroidism, milk alkali, or acute pancreatitis. Hoping I'll all get this right. Oh yeah, 98%, one holdout. You guys are getting better as the day wears on. So this is obviously a case of milk alkali syndrome, the confluence of alkalosis, renal insufficiency, and hypercalcemia. A 54-year-old smoker with COPD, diabetes, and CKD is admitted with pneumonia. Overnight, he becomes more obtunded. PCO2 gets up to 78, so he's intubated. 3 days later, you're called for persistent alkalemia and failure to wean. And here you see the bicarb is 43, BUN's 38, creatinine 2.4, arterial pH is 7.64 with a PCO2 of 41. All of the following would correct the metabolic alkalosis in this patient, except acetazolamide, IV saline, decreased minute ventilation, hemodialysis, arginine hydrochloride. This is kind of a trick question, so I apologize in advance. All right. Oops. Someone's calling to object to the question. All right, so let's see. So 37% of you agreed with me that decreasing the minute ventilation, well, firstly, it's probably not the right thing to do, and secondly, it doesn't correct the metabolic alkalosis, although it would correct the pH somewhat. So all of these other things are maneuvers that can correct what this is, which is a post-hypercapnic acidosis. Metabolic alkalosis, I apologize, because they, restoring volume or getting rid of the bicarb can help. All right, so very briefly, in the last minute, we go through a few scenarios of hyperchloremic metabolic acidosis, and you can select the most likely ones. For a 38-year-old woman with dry eyes and polyarthritis, serum K is 3.4, urine pH is 6.5, urine sodium 28, potassium 50, chloride 57. Do they have a type 2, type 1, or type 4 RTA, diarrhea, or toluene intoxication? Okay, so B is indeed correct. So a classic case of Sjogren's, type 1 RTA, inappropriately elevated pH, positive urine anion gap. Next, 56-year-old Hispanic male with type 2 diabetes, diabetic nephropathy, creatinine 2.3, urine pH of 5, urine sodium 43, K 13, and chloride 41. Should be able to do these in your sleep. Okay. Excellent. 25 right answers. Hyporeninemic hypoaldo, classic. 26-year-old woman with osteosarcoma of the humerus undergoing chemotherapy of ifosfamide, who has a K of 2.3, phosphate of 1.5, and has 2+ glucose in the urine with a pH of 7. Okay. Clearly Fanconi's, and in this case due to ifosfamide, classic cause of that. 24-year-old man with type 1 diabetes, creatinine of 1.8, K of 3, autonomic neuropathy and chronic diarrhea, urine lights as shown. This is causing some challenges. Okay. All right, good. Most of you chose D. So the key here is the urine anion gap is negative, which is appropriate, so it must be due to diarrhea. And I think this might be the last case. A 21-year-old college student with a history of substance abuse, K of 1.9, phos of 1.5, urine sodium of 42, K of 48, and chloride of 12. Okay. And yep, all 12 of you chose the correct answer, toluene abuse, where the hippurate gets excreted and causes a positive urine anion gap that mimics an RTA. And that's it. Thank you very much.